Welcome, everybody. Dr. Lee, I think what we'd like to do is maybe give you about 15 minutes or so to just talk generally about how you are using new imaging and new genomic and other tests in order to give yourself and your patients the best idea of their risk factors and how that may influence their treatment. And then what we'll do is we'll take questions from the panel members, and for the last 15 minutes or so, we'll open the floor open to people who are actually on the line. So with that, Dr. Lee, if you'd like to just take those 15 minutes and give us your opening thoughts, that would be very kind.
Oh, sure, Mike. Yeah, again, thanks for the invitation and the opportunity to talk about what's going on in prostate cancer and in my practice these days. I perform pretty high volume of robotic prostate cancer surgery, and in dealing with this patient group, only 5 years ago it was very cut and dry, very simple. There wasn't a whole lot else to do besides react to what the prostate biopsy showed, and that was typically only because somebody had an elevated PSA or an abnormal digital rectal exam. But recently, there's a whole variety of different options for patients, and honestly, I think a lot of urologists included, besides patients, are trying to figure out exactly how we can best use these tools. I like to think about these different tools in different baskets, so to speak. There's the whole arena of, detection. And then once detected, you have a couple different tools that can help somebody to figure out what treatment option that they might want to undergo. And then there's the aspect of patient care which involves post-surgery, and then what tests are available besides just the pathology report, which can help patients make a better informed decision. So in regards to imaging and genetic tests, which I believe we're going to focus mainly on today, I think one of the big things that's happened, which has I think a big step forward, is we have a little bit better imaging tests these days. I think mpMRI MRI has really helped us to fine-tune our treatment decisions, and then also help us to decide, in some cases, whether to do a biopsy and, maybe determine which patients are appropriate for active surveillance or more aggressive treatment. So in our practice these days, when we see patients with more aggressive disease, so one of the pieces of information that we get from somebody's prostate biopsy is their Gleason Score, and so knowing what somebody's Gleason Score is really kind of the key to everything, because traditionally that gives us the best information on what somebody's prognosis is, and based on that, we can give them different treatment options. So if somebody has lower risk disease, then we start thinking about, especially if a patient is older and doesn't have a very long life expectancy, and a lot of talk these days is about a 10-year life expectancy. And so if a patient falls into a little bit older category, not so healthy category with low risk prostate cancer, then active surveillance becomes a lot more viable treatment option. And so, we really only had PSA, Gleason Score to help us to make that determination. But one of the tools that we're using these days is mpMRI MRI. And so it's a test where patients can go into the MRI scanner. The test usually lasts for about 45 minutes. There's different contrast agents involved, which can help give a picture of whether there's a solid tumor nodule within the prostate, what the blood flow characteristics are of that tumor, and in the realm of guys with less aggressive appearing disease, the MRI can give us some information. One of the things that it can help us to do, if there is actually a sizable tumor nodule in the prostate, then it's very likely that that tumor is actually a higher risk disease, so higher Gleason score, and so that can sway us to recommend more active treatment rather than active surveillance. If somebody has, no tumor visible on their MRI, that actually falls in line with guys with less aggressive disease. Even under the microscope, Gleason 6 disease really appears very similar to normal prostate tissue. And so it's not a big surprise that radiologically it's very difficult to distinguish this. And so, on CAT scan, it's very difficult to get that information as to whether there's any, distinct cancer there, even when it's high risk. But, with MRI, we get a much better picture. And then in this kind of setting for guys with low-risk disease, there are two genetic tests that are now commercially available. One is called Prolaris, and that's made or run by a company called Myriad Genetics, and they're based out of Salt Lake City in Utah. And then the other test is Oncotype DX, and the company that provides that test is Genomic Health. And so these tests both aim to better characterize the aggressiveness of the prostate cancer. So, one of the constraints that we had with Gleason score is that, we know that 90+% of guys who have Gleason 6 disease will do very, very well with treatment, either with radiation or surgery. They'll have a very high success rate and not need any extra treatment afterwards. But, there is that 10% of patients who won't do well. And, some of those guys will go on to have metastatic disease and end up dying of their prostate cancer. So, one of the things that we know is that not all men with Gleason 6 disease behave the same. And so there's something else going on that we can't really put a finger on until, we have the help of some of these genetic tests. So the Prolaris test and the Oncotype DX test as well, they both work or are sampled by actually examining a piece of the biopsy tissue that was performed at the time of the standard prostate biopsy. And so these very small specimens can be obtained from the slide, and they only need about a 1 millimeter section of tumor, and then they can run these genetic tests. And so the idea with both of these tests is that they look for RNA expression in the cells. And so they can extract the RNA, which, I think the technology in and of itself is really amazing. But then the Prolaris test, they look at 31 genes in particular, but these 31 genes are cell cycle proliferation genes. So they're more active or they're more upregulated in the arena or situation where the cells are more rapidly dividing. And so, that goes along with aggressive cancer. The cells are dividing at a quicker pace. And so, these tumors are, more likely to spread. So looking at that result, if somebody has a higher Prolaris score, then that gentleman will have a more aggressive prostate cancer. The Oncotype DX test, they look at 17 genes, but these tests are looking at a whole variety of different cell functions. Some of them are androgen receptors, and so we know that prostate cancer is very sensitive to the presence of testosterone. And so, obviously this would be important. There are some cell cycle proliferation genes that they look at, cellular organization genes. And then both of these tests also look at a set of reference genes. So, kind of housekeeping genes that are turned on all the time. And so that's what you compare all of these other genes to. And so basically the higher the score, the more risk there is of an aggressive prostate cancer. The Prolaris test gives the information of actually mortality, which is interesting because it was validated by looking at a cohort of patients from Great Britain who chose to actually not do any aggressive treatment after they were diagnosed with prostate cancer and basically underwent a watchful waiting protocol. And knowing what the eventual outcome of these patients were, they were able to look at the test with the benefit of the tissue diagnosis and validate how well their tests actually function. The Oncotype DX looked at a different cohort of patients. A large cohort was from University of California, San Francisco. They looked at whether a little different outcome. They are looking at whether the patients on final pathology report, if patients go ahead and get radical prostatectomy, what the chances are that their biopsy will look like what their pathology report looks like. And so, if you have a higher score, then it's more likely that the patients will have more aggressive pathology. If you have a lower score, then that will correlate to a more favorable pathology on final pathology after surgery. The multiparametric MRI, I think, is also very valuable when patients have decided that they want surgery. I use it standardly on all the intermediate risk and high risk patients. And so these are the guys who would have a PSA greater than 10, a Gleason score of 7 or higher, or high volume disease. And this can be used as a really nice planning tool as to how much nerve saving we can do for the patients. These days in prostate cancer, we're dealing with a whole variety of different patients. There's a lot of the older gentlemen, which we traditionally identify with prostate cancer patients, but there's a lot of younger guys too who are very worried about their quality of life, their potential for having urinary incontinence and erectile dysfunction. And so having this roadmap, so to speak, really gives me a better idea of what kind of operation that we can do as far as nerve sparing and preserving that kind of function.
Dr. Lee, if I may ask, do the results of these tests really, do you feel, help men to come to conclusions about whether they are good candidates for active surveillance? Obviously it's a problem for a lot of men in just, taking that step to say, I don't need to do anything yet.
Right. So I think that remains to be fully proven. There have been a couple studies looking at whether it influences physicians. And so when physicians are presented with case studies of patients, both with and without their genetic test results, the genetic test results actually do seem to influence the recommendation that the surgeon gives to the patient as to whether they need treatment or can do active surveillance. It is a very, this whole, situation men find themselves in when they're at this point of trying to decide what treatment option to undergo or to do active surveillance. I feel really bad for a lot of these guys because it's a very difficult decision to make. It has a lot of outcomes as far as their quality of life goes, and then they're looking at their whole issue of mortality. Is this something that's going to kill me or not? And so to choose to do active surveillance when you hear the diagnosis of cancer, it's a daunting task. But I think if somebody can take the time to look at what the data means, I think the genetic tests actually do provide some really good information because, looking at these validation studies, the information that you get out of these studies actually has a very separate prognostic value when you compare it to Gleason score and PSA. And so, I think a lot of us urologists, when we first started looking at these tests, we'd go, oh, well, how does it compare to PSA? How does it compare to Gleason score? And so if you see a genetic test result that's discordant from your Gleason score, then you're going to go, well, this test doesn't really work, because we know that Gleason score is such a powerful predictor. But, these tests are actually telling us some separate information and, can help us to really figure out these guys with Gleason 6 disease who look otherwise very low risk, but may actually be one of these guys who goes on and does poorly. I think that's another important point for men, is that you do have to take your time and figure out, what the data means, what kind of tests are out there and available, because prostate cancer has really changed in treatment and diagnosis and testing.
And being based in Philadelphia, I assume you see African American patients on a fairly regular basis. Is there any distinction in the use of these tests in that population, given that they do seem to be at higher risk to begin with?
Yeah, no, that's another area that hasn't been well studied. I think it's a very important area for us to look at because I think most of us who treat men with prostate cancer, if you just take an African-American guy who has exactly the same numbers as somebody who's Asian or Caucasian or Hispanic, the African-American guy seems to do worse, even with the same Gleason score, same PSA. And so, there's got to be something else going on. And, it's quite possible that one of these genetic tests can help us to pick out those guys a little bit more precisely.